Hi everyone, my name is Luke, and our group will talk about the end of life care as well as the advanced directives. For the introduction purposes, I'm going to briefly talk about the end of life care as well as the advanced directives. Starting with the end of life care, it's the medical care that supports the patients who are approaching the final stages of their lives. And the primary focus is to alleviate or prevent any kind of suffering while honoring the patient's wishes. So there's two types of end of life care. One is palliative and the other one is hospice. Patients who choose to go to hospice care, that means they understand that their illness isn't responding to the treatment anymore. So they're focused to the treatment focus shifts entirely to comfort rather than curing the actual disease. Whereas in palliative care, patients can continue with their treatment to cure their conditions on top of the pain relief aspect of the medical care or the end of life care. So when the Patient Self-Determination Act of 1990 was introduced, it actually required, it started to require all the healthcare facilities to ask the patients if they have the advance directives or not. And if they don't, they have to provide the patients with the information so that they can make one. Also, as a future physician, it's important to keep in mind that the specifics of advanced directives can vary from state to state. So, for example, in Washington state, the advanced directive is only applied when life-sustaining treatment would unnecessarily delay the dying in the terminal cases or when a patient is in an irreversible coma. So why is it important? Um, well, this is the direct quotations that I found from the article. There's a link at the bottom of the slide, but it really helps not only the patient but also the family members. So I don't know if you remember one of the videos that we watched in the class. It really showed how burden it could be for the family members when the patients are not able to make the decisions for themselves.
Standard be adopted? And if the standard is adopted, what role should medicine have regarding the criteria that needs to be met? This case helped really pave the way into answering the question, is brain death considered legal death? It also helped many states adopt the Uniform Determination of Death Act, which at first was a common law for determining death, was just total failure of the cardiorespiratory system. But after this case occurred, they added to the common law, making it include new procedures for determination of death upon irreversible loss of all brain functions. So ultimately, this case did make a breakthrough for the state of Washington, and it also helped many other states adopt the standardized Uniform Determination of Death Act.
Okay, so next we'll be talking about patient autonomy. And patient autonomy is connected to end of life care and advanced directives as it ensures that individuals basically have control over their medical decisions, especially during moments when they cannot speak for themselves. And in this slide, you can see that patient autonomy also helps to prevent unwanted treatments and overall just provide comfort and respects the patient's wishes. So next we'll be looking at a brief case study. So this case study is called Ethics in Palliative Care. And this article basically highlights the case of a patient, Mrs. A, who's a 40-year-old woman with advanced pancreatic cancer, who's in a lot of pain, but her autonomy is compromised by both her physical condition and the influence of her husband. Her husband basically is opposing the use of morphine to treat the patient because of concerns about morphine side effects. And this scenario raises important ethical questions about who has the right to make medical decisions in scenarios like this. And Mrs. A, she does want to maintain peace with her husband, but she also wants her pain to subside. So, she has to kind of balance what to do in this scenario. And the overall message of this article basically emphasizes the importance of open communication between not only family members, but, patient, healthcare providers, and everyone who is involved.
Harm onto their patients. And from the advanced directives of Lecture 8, non-maleficence is seen in advanced directives such as DNR, where providing the patient CPR can be harmful even if the intentions of the physician are good, as CPR can cause rib fractures onto elderly patients. And furthermore, some patients may consider certain treatments to be harmful or may cause more harm than good and could prolong their pain and suffering. And that's why having a living will gives the physician the understanding that the patient may want to forego any aggressive treatments, and so the physician will not be doing any harm unto them. And with the New York most, the patient's preference for life-sustaining treatments is crucial for non-maleficence because preventive treatments like artificial ventilation can be seen as harmful by the patients and would cause more distress to them rather than being helpful.
Beneficence in the topic of advance directives involves the physician defending the most useful intervention for a given patient and considering what is going to be of the patient's best interest. Oftentimes, the patient's wishes aren't expressed through advance directives, or the patient is incapable of decision making. This causes the physician and family members to be unaware of their wishes about end of life care. This is where the responsibility of the physician comes into play, advocating and finding the best care available for the patient by consulting with the patient's family or healthcare proxy, as well as overcoming any barriers by taking in consideration of cultural influence, such as the patient and their family perspective on death, hospice care, spiritual, religious beliefs, and many others. This will lead to formation of trust to make a shared decision that will offer the best care for the patient.
Before we conclude this presentation, we did have a few thoughts. So we hear some iteration of the phrase, patient communication is key, repeated by rote in any conversation concerning medical ethics. However, by nature of the physician-patient relationship, this communication is often circumscribed by the physician's training and understanding of the issue at hand. We hope that this presentation has expanded on this statement and brought to light the many considerations surrounding end-of-life care. Perhaps paradoxically, end-of-life care demands that physicians have culturally sensitive and informed discussions with patients about how they want to be treated during the end of their lives. We argue that these conversations should take place at every stage of the patient's life, but for this assignment, we're focused on end-of-life care and planning. Our research led us to resources that call for physicians to ask patients about their beliefs, no longer assigning spirituality to the purview of the chaplain, but rather understanding that for some cultures, spirituality may guide the way patients explain their symptoms or ask for relief from these symptoms. In step with the life course model of health, we found that many of the same disparities continue to plague patients in end-of-life care. According to the Agency for Healthcare and Quality, non-white patients were less likely to receive the right amount of emotional support. The ethnically diverse hospice patients were less likely to receive end-of-life care consistent with their wishes, and the ethnically diverse hospice patients were more likely to report poor communications with their physicians and nurses. If a physician is unaware, as in the cases described by the National Head, Blood, and Lung Institute, that when asked about a patient's pain, he will point to his heart to signify the psychological pain that he is feeling, it is impossible for the physician to help the patient as he or she does not have a fundamental understanding of what the patient is expressing. One point that should be noted is that while Western Moors may insist upon aggressive treatments that often result in patients spending last days in hospitals, many cultures have a less intensivist approach to dying and thus are more in line with hospice practices in which the patient receives comfort care at home. We see the interconnectedness of all aspects of patient care when we discuss the principles of patient autonomy, non-malfeasance, and beneficence with regard to end-of-life care. Western medical practice dictates that physicians share a patient's health status with that patient, but other cultures consider it unkind or taboo for a physician to tell a patient that he or she is dying. Being knowledgeable about these differences will help physicians understand the distance they must travel to discuss care planning and the importance of advance directives.